So thanks for the invitation, Diane. Thanks to everybody for coming on such a nice night. I know some of us were stuck in traffic, but we eventually made it. So what I want to talk about is, I guess, maybe dispelling some of the myths that are out there for lymphatic surgery. I've learned some things in my training and residency and in my fellowship that were a little bit different. And then in practice, I've sort of adapted things even more varied. And I think I go to some of these meetings for lymphedema, especially lymphatic surgery, and I'm sort of astonished by some of the things that are being done. And I sort of sit there nice and patiently and see how things turn out. But I've adapted some of it. Some of the things are logistical nightmares that we're dealing with from a medical standpoint, but we're getting there. So thought I'd just share what we've been up to and maybe what you have heard about. Might have to advance this here. So I think this is, I think everybody's probably been through this, the people that have lymphedema. Have a little bit decreased knowledge on it, just because it's not really introduced that much in medical school, not much is paid attention to the lymphatic system and lymphedema. Certainly heard from patients that have gone into emergency room settings with cellulitis and that they think the patient has flesh-eating disease and never really heard of lymphedema. So I think this is probably part and parcel of the whole illness and what people probably experience. So as I mentioned, it's really sparsely described in the medical literature. So any textbook in medicine really doesn't have very much about it. They may discuss classification, they may discuss some of the non-surgical management. Most of our anatomical knowledge is actually based in the 19th century. So it's based on mercury studies, which nobody wants to replicate these days. And then from there, it's just, it sort of hasn't really changed. I think some of what we've learned physiologically, surgically, has been with the imaging techniques that have recently came out that we've learned. But I still think we're still taught what the lymphatic system is for, and it's trying to restore that fluid balance. So it's trying to return fluid back to the system. There is definitely an element that is part of immune regulation. So it is involved in transmitting or transporting pathogens to lymph nodes so that you can activate the immune system. And then something to do with lipid absorption from the GI tract, which we'll talk a little bit about when we get into one of the surgical management options. So this is a schematic that wasn't really developed even 20 years ago, 25 years ago. It was the different layers of the lymphatic system. So on the top, you can see the epidermis, and then as we get further down, you can see the dermis, and then subcutaneous tissue and deep tissue. Some of the surgery that was done that we'll talk about 25 years, 30 years ago was done in the deep tissue, which is what it is. It's deep. It's underneath muscle. It's often very close to bone. It follows the major blood vessels of the body. And frankly, you probably cause lymphedema going in that plane. So things that have been developed in the last 10, 15 years are concentrating on things that are more superficial. So what we look at a lot is the subcutaneous tissue, so the superficial collecting vessels, and seeing if we can reroute things through that pathway. Interesting enough, there's no communication between the subcutaneous and deep tissue collecting vessels, which is intriguing for a system that was fundamentally built to return fluid to the circulation. So everybody here knows what lymphedema is. So it's an imbalance. I thought this was from an article I was looking at recently. Just it's between lymphatic load and lymphatic transport. So either you have too much, or you have the right amount, but you just can't transport it. And somewhere in that schema, people will fall. And that's where we get into talking about primary versus secondary causes of lymphedema. So with primary lymphedema, a couple different classification systems, but this seems to be the most common. You can have it basically born with it, called Milroy's disease in some. It's thought to be autosomal dominant. There is some evidence coming out with some of the genes and maybe the proteins that are encoded. And one of the universal ones always seems to be VEGF. So if you ever sort of look at the literature, you'll often see something called VEGF, called vascular endothelial growth factor. And it sort of plays a role in a lot of the development of lymphedema in theory, but hasn't really been applied that much into human studies. The second one is lymphedema precox, which develops a little bit later, usually in puberty or early 20s. And again, it's thought to be autosomal dominant, and they're trying to find another gene, which is the FOXC2 gene. Lymphedema tarda is something that develops a little bit later, so in the 30s. And all of these sort of have an idea of what's going on. But the first one, precox, being just an absence, or sorry, lymphedema congenita being an absence of lymphatic collectors. Lymphedema precox being hypoplastic, and this one actually being hyperplastic is the thought process. Secondary lymphedema, the most common, definitely in North America, always classified as being acquired because it's due to something, and it's a damage or disease to the lymphatics or the lymphatic system. And still, what's always documented as being the most common in the world is infection, filariasis, parasitic infection. We rarely see that. I think maybe I've seen one case. And then some of the other infections such as TB, inflammation. So really anything that can cause ramp up the inflammatory system, which then recruits more fluid to the region. Things like lymphangitis, so cellulitis, chronic venous stasis, snake bite is always talked about. Connective tissue disorders, so rheumatoid arthritis, psoriasis does have some incidence of or prevalence of lymphedema. Iatrogenic, so axillary lymph node dissection or groin lymph node dissection for staging of cancer is the most common. Radiation definitely has some impact on the development of lymphedema. Trauma, one of the mechanisms. So again, you're sort of ramping up that inflammatory system, and then simple malignancy outside of actually any surgery can cause lymphedema. So again, most prevalent for us, breast cancer is the most common that I see. Sarcoma, so that mainly lower extremity. Melanoma, again, lower extremity. Gynecological cancers has a relatively high incidence or prevalence. Axillary lymph node dissection, so breast cancer, and then you have lymph nodes removed, does have a varying rates. So I would say it's safe to say 30%, 20 to 30% will develop lymphedema in their lifetime. And they occur relatively quickly, 2 years, like not instantly, which makes some of the therapies for prevention a little bit difficult to accept amongst the medical field. We'll talk about that. But very high rates in inguinal and femoral lymph node for gynecological, so 30% lower extremity. So this was an interesting idea that was put forth by Kataro and this year, and they were saying that that it's more of a predisposing factor. So having a lymphatic, at least in case of secondary lymphedema, lymphatic injury is just an initiating factor. There has to be other things, and this comes down to that not everybody develops lymphedema. So if you have all of your lymph nodes removed, 25 lymph nodes removed, and you may develop lymphedema, but you may not. So you should if it's the only thing that's going on. So presumably there are other mechanisms or there are other factors that are taking you over that tipping point, and that might be radiation, that might be an incidence of cellulitis, obesity, huge risk factor. So we know from studies that those that are a little bit more overweight will actually develop worse lymphedema, or harder to actually control non-surgically or surgically. And then genetics. So again, that's something that is slowly playing out, and hopefully in my lifetime we'll actually figure out some of the genetic mechanisms. But slowly making its way. A lot of it was limited by not having an appropriate animal model. So that's anything that we do in medicine needs to have some sort of animal model that can be replicated and then maybe eventually applied to the human population. And they had limited animal models and still sort of do for lymphedema. So pathophysiology, so why does it occur? Again, we sort of talked about it. It's the load and it's the transport. And if you get a backup, you get a backflow, you get dilation of valves, and you get fluid backflow. So that then sparks inflammation, which is some of the research areas that they're addressing is trying to address that inflammation. So how can you maybe shut that inflammation down early before it actually develops? Thought to be T cell mediated, so CD40 T cell. So some of the factors that are being applied are trying to address more inflammation. Inflammation, again, as we talked about, leads to edema. So it eventually leads to some fluid accumulation. And then something that's been proposed for about 10 years and is coming to light, there is that interaction between the fluid that's hanging around and fat formation. That fluid is sparking fat formation, that inflammation is sparking fat formation. And then eventually fibrosis. So they don't follow that nice sequence, and they can all occur at once, but eventually if lymphedema is left untreated, you get a fibrotic limb, and you get a limb that has increased volume, which is not only due to fibrosis, but also due to fat accumulation. So that relationship between fat is seen in the top one with the obesity. So obesity just making your lymphedema, the chance of developing lymphedema, the extent of lymphedema is higher and is greater. If you do an MRI, if you do any other assessment of a lymphadematous arm or leg, you'll actually see increased fat formation. And part of that is likely the reason why some people eventually don't really do very well from non-surgical management, because it's hard to get rid of fat once it's formed. And again, there's that VEGF playing a factor in this response to inflammation. So this is a schematic of what on your left side is healthy looking tissue. So the top being skin, the bottom being muscle, and you can see the various compartments. The middle one being the subcutaneous fat or fatty layer. And as you progress from acute cases to chronic cases, you can see an enhanced inflammatory response, an enhanced thickness of that middle layer. So you are getting a very thick fatty layer in cases of lymphedema, which is important to remember when we come up to one of the surgical options. And I'll remind you when we get there. So diagnosis, I'm not going to go into a lot about signs and symptoms. Everybody who's here has somebody either that they know of or they're a patient themselves. So you can tell me more. You know more about it, the signs and symptoms and what you deal with, struggle on a daily basis than I do. But what I've seen is diagnosis is tough for some individuals. And lymphedema patients are often called medical nomads because they don't know where to go. You got a swollen limb. Okay. See, here's an ultrasound requisition. So I think misdiagnosis still occurs or is delayed. And I certainly see it in Calgary. I see some physicians that think they can't order some of the tests for lymphedema, even though it's, I'm not any special than anybody else. I could fill out a form. But it seems to be difficult to actually find somebody that's willing to address it and get the process rolling. Lymphoscintigraphy is the test I'm talking about. I wouldn't say it's minimally invasive. It takes a long time to get it done, but it provides a lot of evidence and a lot of indications for us of what's going on, and it measures the time and the degree of lymphedema, and it's a test that can be ordered by any physician. And then the bottom point, yeah, still a little interest. So again, it comes back to that first slide where don't know how to pronounce the name. So part of it is the exposure during training, where it's not really talked about very much. You look at an anatomy textbook, the arteries are red, the veins are blue, and the lymphatics have this little tiny wedge beside those vessels that is yellow. And that's all it is. It just, that's part of it. I think that's the start. And I think the bottom one is that it doesn't easily fit. So it doesn't fit into an area that somebody just wants to take on and take over themselves. I think the surgical oncologists, especially for cases of secondary lymphedema, have it in the back of their mind, and the clinics are somewhat set up to hopefully diagnose it early. But I think that there's still not quarterbacks willing to take on the role. This was an interesting one out of Boston. So it was a study in 2015, and they looked at referrals to their lymphedema center, which is a fairly large lymphedema clinic. So multidisciplinary, medical, family physicians, physiatrists, physiotherapists, occupational therapists, surgeons, all at this clinic, and they had a long wait time. So this is actually, I think this is actually insured patients. So, which usually, they get what they pay for. So, and it was 8 years to get a referral, which is shocking. 75% of those actually had lymphedema, so that's good. They actually finally got to the right place. 34% of those received prior tests that were non-diagnostic. So that's where it comes up with X-rays, some certain blood tests. So some unnecessary things that were ordered. Only 4% had lymphoscintigraphy. So the actual diagnostic test for lymphedema that has been around for ages was not done. And then 30% had no treatment. So they weren't even started on non-surgical management, the complex decongestive therapy, nothing. 10% were given diuretics, which actually makes lymphedema worse. So, I think, this is something that probably was the height of a great clinic in an insured population that usually gets, I don't know if anybody's ever lived in the US, but you can get in to see your family physician the next day if you have decent insurance. So, and that's what this showed. So this is lymphoscintigraphy. So again, it's the gold standard. There are other ones out there that I'll talk about later in this presentation that are making their way to the forefront. Obviously, they're always a little bit more expensive. But this one uses a radioisotope, and it's tagged and it's injected, and then sequential images are taken of the patient, of their affected limb, and you can follow the transport. You can follow the transport of that tracer at certain time points, and you get things like this. So the big blotch that you see at the top is the liver. So it's something that's excreted by the liver. On an A, on the right side, you can see some little darker, I wish I had a laser pointer, but some other blotches right there. And then on the other leg here, so you can actually see more on the left. So this is showing mild lymphedema. So some of it is going to the lymph nodes. That's what those other blotches are. And then as you progress over, you can see less on this one going up, and you can see actually a lot of backflow in the leg. So you don't see that on the left side. So it's actually going in the lymph nodes, and it's going in the liver. On the next one, you can see even more severe. So it's actually not even making it to any, well, maybe one lymph node, and then the rest is backflowing. And on this one, it's the left leg that's affected, and you can see no flow. So it gives you an idea of what's happening in the lymphatic system, and where the backflow is occurring, and what kind of transport you have. And it's not rocket medicine. This is a nuclear medicine test that can be ordered by anyone. So I think what most people came here listen to was about treatment. So I wasn't going to spend a lot of time on demographics and incidents and um, characteristics and that sort of thing. I thought, let's talk about treatment. That's what people are here for. This is what I was taught. This is what I was taught. The first three in my residency training was never operate on a patient with lymphedema. It's non-surgical, non-surgical, and non-surgical. And I think maybe only operated on one patient with lymphedema in my surgical residency. Granted, some of the procedures that I'm going to talk about weren't really popularized by them at that point. So I think non-surgical management is still the preferred treatment. It's still the mainstay. It's still what you have to be. You have to buy in. You have to be all in for the non-surgical to even really consider going down the surgical path. It's definitely not the primary. So I think what articles in the literature and textbooks and what I found is that patient selection is difficult. So some of the big names in the field, and we'll sort of show you some of them, have their own algorithms, and they say, oh well, it's this person has this stage or grade, well then go to this right box, and if they don't, they go in this left box, and some who are the large names in the field only really do one or two of the techniques, and they promote it hard, and I've learned that from attending these meetings because they're the ones that give all the talks. So I think that leads into that there's a lack of evidence. There's a lack of evidence for what is the optimum management. I think non-surgical decongestive therapy, manual lymphatic drainage, all that is still the mainstay. What we're trying to add with surgery is trying to enhance the flow a bit. I think, my opinion is, and this will come at the end, is that compression garments will probably never be removed. I think it will always be a mainstay of your lives. And I think that I struggle because I see, some of the people that are out there trying to say certain things and trying to say, oh, you gotta get rid of it. But I think you have to take it with a grain of salt. I'm hoping that's what you get out of tonight. Again, multiple algorithms, but yet there's still expanding interest. And I don't know why, but in 2016, both these textbooks came out. No textbook before, but they all came out, and they're different surgeons. So on the right side, you can see Meng Wei Chang, who's from Taiwan, and he publishes a lot. He's been doing it for 25 to 30 years. His second author is a guy named David Chang, who's down in Chicago, and he does a lot of lymphatic venous anastomosis, or LVA, that we'll talk about. Keaton Patel is in Los Angeles. He wasn't there when I was there, but he does a lot of lymphatic surgery at USC. On the left side, Peter Nelligan was originally a Canadian surgeon who's in Toronto, and then he eventually went to Seattle and is really one of the pioneers in microsurgery. Probably I haven't seen anybody who has as much dedication as that guy. He actually gave a talk from his hospital bed one time by a camera. He recently had a heart attack, and he's given a talk at a lymphatic meeting. And Hami Mazia is from Spain. So, you got a full gamut of individuals, and I think the Americans have came on board and really expanded the research element and are trying out different techniques that we're still trying to figure out the long-term outcomes of. So when I thought of surgical management, the bottom two are really what we think about in people that have established lymphedema. Preventative surgical techniques are something that should still be considered, and some of you may have already gone through one of those with a sentinel lymph node biopsy in cases of breast cancer, and that's the first one. So instead of just clearing out all of the lymph nodes, why not just label certain ones that are actually draining the breast and sample that one and see if it actually has any cancer cells in it? And that's what sentinel lymph node biopsy is. It reduced the risk. So 6 to 10% of people who have sentinel lymph node biopsy develop lymphedema. So that doesn't eliminate to zero. And so that's a matter of, again, you're having lymph node surgery is probably just a predisposing factor. It's just an initiating factor, and then other factors are at play. But it's less commonly used in gynecological surgery. So for lower extremity lymphedema, it's never really been adapted and instituted as much, maybe more now, but not in my training. It was very rarely used. This led into the concept of reverse axillary mapping, or axillary reverse mapping, ARM. And it thought that if you could label the lymph nodes that are draining the arm and label the lymph nodes that are draining the breast with different dyes, then could you preserve the ones that are draining the arm or leg and just remove the ones that are draining the breast? And it seemed to work. It seemed to have a reduced amount or reduced chance of lymphedema. Again, didn't bring it down to zero, brought it down to 4%. But it also, there was some crossover. So some of the lymph nodes that were labeled from the breast and some of the lymph nodes that were labeled from the arm actually were together. They had both died. And it was very small numbers. It was like 3 to 5%, but that's enough to actually potentially leave a burden of cancer. And so it never was something that really took off. And probably the general surgeons didn't like people in there injecting dye in the arm, and it was wasting their time. But it was that risk that it never really got fully adapted. And maybe it's still has a role, but I've never seen it used at all. This led to this one, which has been around for a couple years, actually mainly out of Boston, and they had an interesting name, Lympha. So trying to reconstruct the lymphatics at the time of surgery. So saying, okay, surgical oncologists, you can remove whatever you want. You need to for lymph nodes for staging. We'll just find out what those lymphatics are that you've now damaged, and then bypass them and take them into a nearby vein, which is usually up in the armpit, is something called the axillary vein. And it did have evidence that it decreased bouts of or prevalence and incidence of lymphedema. Obviously, it takes time, so it takes coordination. Now you have to find a surgical oncologist that's already planning to remove the cancer, sample the lymph nodes for staging, and then you got to find a reconstructive surgeon to do it at the same time. It's basically trying to reconstruct breasts at the same time as the mastectomy, which is a task in itself for offices. And then injecting various dyes. The effects of it over time aren't known because it's so new. We don't really know what happens with radiation. Does radiation cause these little guys to collapse? Does chemotherapy cause these little guys to collapse? And so it's sort of on the cusp of being the next probably advance in preventative surgical management after the sentinel lymph node biopsy. So it's got some interest, but again, not routinely done, and definitely not done in Calgary. So the second treatment option is really the older ones. And so this was that if you had something that was of large volume, just excise it, just debulk it, we call it, or remove it. And the most aggressive one was something called a Charles procedure. So it's been around since probably early 1910 or something. Charles was a surgeon of King George V, I believe. And so he came up with this idea that, well, can't just remove it all and then take everything down to muscle and skin graft it with what you just removed. And it was really the only thing that was available for years. And it's not attractive. Like, it's not something that anybody's, oh great, I'll do that, because it cosmetically very disfiguring. Potentially could make your lymphedema worse, especially if you're removing a chunk of tissue from the leg and you're leaving the foot. Well, the foot might get worse because now you're basically removing all any existing lymphatic channels. And infection risk, and then chance of coming back. So it never really was a huge surgical technique used in North America. You know, in other countries with very severe lymphedema affecting the leg, where patients' only option, such as this one, is amputation, then it was applied. And you can see on the top the leg with lymphedema. You can see on your left-hand side what was excised. It was just unwrapped, and what you're seeing there is fascia or muscle, and what you're seeing on your right-hand side is a skin graft, so taken from the area that was removed. So fairly significant. So then some of the surgeons came up with another idea, saying, okay, well, people didn't like that too much. So let's try something differently. Let's see if we can make an incision and keep it fairly thin, the skin and some of the fat, and then just basically remove everything underneath, and then close it back up, and then come back another day, 3 to 6 months later, and make an incision at like the 6 o'clock position instead of like the 12 o'clock, and then come back and around and remove the rest. It was something called the cyst trunk. Didn't really find that it had much improvement. So it was a decent concept. This is the concept. So in a leg, you make an incision on the medial aspect, and what you're seeing on the right is where the incision is made down deeper, elevated everything, remove everything underneath, close it back up, call it a day, and then come back another day and remove the rest. And same thing for arm. And it made sense because you're removing that extra tissue, you're removing that fibrotic tissue, but it really didn't have outcomes that were, its outcomes are worse than the Charles procedure, really, because your volumes were still fairly large, and you had incisions that potentially could get infected and pretty lengthy. So it was never adopted. So that's two of the excisional procedures that in rare instances, I think in North America will be used. That leads to the third one, so liposuction. So liposuction was never really developed for lymphedema. It was developed for you know, the patients that you see in botched that want to have liposuction on their abdomen, or it's for cosmetic purposes. And it was developed in the mid-'80s, and it was used for removing fat. And when it initially was developed, it was a massive blood loss procedure, because nobody really figured out that when you're taking a cannula and putting it in tissue and then repeatedly trying to suck out, you could actually spark a lot of bleeding. And so by the late 80s, they figured it out that, you know what, we need to put fluid in there. We need to put fluid in there that actually has epinephrine that constricts blood vessels. We need to put fluid in there that has local anesthetic. And we need that fluid to actually make that fat a little bit fluffier, a little bit, so it's easier to remove. And liposuction took off from there, because then it became a much less riskier procedure, to the point where the amount of fluid that is often put in is 3 to 4 times the amount that you're actually going to remove. So its application in lymphedema isn't really addressed, it's not to address the fluid component, it's to address that fatty component. So once again, that fatty tissue is accumulating, and due to inflammation, and it's seen not only subcutaneously, but some recent studies have shown that it's in muscle. So we're not going to address that. We're not going to liposuck your muscle, but you can definitely liposuck in the subcutaneous plane and remove a lot of volume. And again, sort of that buildup of fibrosis, that buildup of fatty tissue is the reason probably why that those compression garments, the non-surgical management, can only go to a certain amount, because it's hard to squish that fat. It's hard to squish the fibrosis. But with liposuction, you can remove some. So again, there's that schematic. So just that layer of fat is expanded. And so that's what is attacked in liposuction. Some of the techniques that we're going to talk about, the physiological, which is microsurgery, doesn't address that volume. So what the physiological procedures are trying to do is they're trying to reroute that lymphatic fluid. It's trying to basically solve what your issue is, but it has a hard time doing it if you have a lot of volume. So that liposuction then becomes a value for those individuals who have extremities that are very hypertrophied, that are very expanded. But again, the caveat is that that is maintained through compression garments. So it's one that you will not be able to get rid of those, because the individuals in the world, the surgeons in the world that have the greatest results from liposuction are heavily aggressive in their compression garment usage for their patients. They won't tell you that. That's something I had to find out on the down low. But they remove a lot of volume. Like we're talking about 2,000 milliliters of fluid, and if you think we sort of equate that to 2,000 milligrams or 2,000 grams, that's a lot. So, this is one. So if you see on the left, the arm with lymphedema, and on the right with the finished product intraoperatively, that's a lot of volume that's removed. The color difference is because they have a tourniquet on the bottom, so don't be worried about that. But that's what you can get out. You can get a lot of volume, and the procedure itself is probably 2 hours, so you go home the same day. But again, needs that compression garment. So the outcomes, which everybody cares about, 100% reductions, some of these surgeons. So mainly European, and Brorson in 2015, huge follow-up, 21 years. You don't see that in medicine. You certainly don't see that in surgery very often. I think it was 146 women with upper extremity lymphedema secondary to breast cancer, and maintained as long as you're compliant, as long as you know that you're going to have to still be in the queue of wrapping and garments. The reductions are maintained. Health-related quality of life. So there's little forms that are filled out called SF36, and all of them were improved with liposuction. And mainly the incidence of cellulitis is reduced. So of all the surgeries that we've seen, except for those very graphic ones, those first two, cellulitis is reduced in all of them. So that's again a nice plus with liposuction, from what's been seen in meta-analyses and a variety of different research studies. So now that was the excisional. So that was removing that extra tissue, which sometimes needs to be combined with physiological procedures. The reconstructive or physiological are ones that are often the talks that are the key points of the meeting that happens every year, called the American Society of Reconstructive Microsurgery meeting, which has a lymphatic surgery component. And you never see anybody talking about liposuction. You never see anybody talking about that Charles procedure. But you see certainly all the different types of physiological procedures that are nice and sexy that everybody shows. And this is really where most of the advances have happened in lymphedema in the last 20 years. And there's various options, but they were always fairly inconsistent, because 25 years ago, the optics of a microscope weren't great. You could go to a certain amount and zoom, and that's all you could see. And really the limitation for us as microsurgeons putting an ear back on or putting a finger back on wasn't really due to the microscope. It was actually due to the sutures. So trying to find a little metal needle that was small enough that could hold that suture, and then actually having instruments that can hold that was the major holdup for most of this eventually coming to fruition. And there's been fairly significant advances in the different types of titanium kind of instruments that are fine, to the point where we have some of them at my hospital that I don't let them out of my sight almost, because if you just touch them against another piece of metal, they're basically done. So and then the mapping, so visualization and mapping. So it's not realistic to expect that you can bring lymphocytography into the operating room and sit there for 3 hours or 4 hours and say, okay, well, there it is, and draw it out. You need something that's a little bit more user-friendly and is available and gives you, access and visualization of lymphatics as you're there. So real-time imaging. But again, as we're going to see, there's really no standardized protocols. So what I found again is that there's surgeons that are promoting certain things, and that's the cat's pajamas, and not sort of considering the other options. And that's, you know, certainly the ones that are at the meetings and that give all the big talks and that have the chapters and textbooks heavily promote what they do. So this was one of the techniques that came out that allows us to have real-time visualization. So it was something that was used in ophthalmology, and it's been adapted in neurosurgery for labeling tumors. But eventually we got applied to lymphedema, and it's a dye, a green dye that is fluorescent, and you need to have a camera that's infrared, and you can inject it into the dermis, you can inject it wherever you want, and then you can activate the camera, and you can visualize lymphatics. So you're visualizing those superficial collecting ducts, and one's in the epidermis, one's in the dermis. It doesn't really go much deeper than 2 centimeters, so you're not going to see those deep ones. I don't think it's still used for diagnosis. I think lymphoscintigraphy is still the gold standard, but it has helped label lymphatics intraoperatively as needed so that we can find them, and that then we can make sure that what we do is actually being done right and is successful. So therefore it provides detail in terms of operative planning. This is what the machine looks like. There was a company actually out of Vancouver that made this one. It was called Novidac. They got bought out now, like most companies do. And they called theirs the Spy, and they always had a thing that said the Spy never lies. And we use it also for, we can inject it intravenously. You can look at fingers that we put back on to make sure they're alive. And it labels what you want it to label. So, so the Spy is something that we have. There's only one in the city. And talking to one of the authors that I talked about, Peter Nelligan, said that you cannot do lymphatic surgery without this machine. So we're fortunate. So this is what you look at. So on the left, this is what you're seeing where it's been injected into the hand, and you can see some drainage of the lymphatic, of the indocyanine green, and then what we do is we just do the simple thing, drawing marker all over your arm, and then flipping it over, and this is on the palmar side, and you can see these little channels. So those would be ones that would be addressed. If you had those, that means they're intact and still functional, and could be addressed in one of the surgeries called lymphatic venous anastomosis, which we'll talk about. This is a video that plays of one of my patients. I don't know if you can see that very well. But you can see some of the things that are lit up, and then putting marker all over the arm. And then sometimes you can actually see forcing the dye through. So it's actually being pushed through that lymphatic channel. Sure, yeah. Let's stop it there. There we go. Yep. Yep, that's good. Okay, so there you can see it. So this is an arm. The white is the indocyanine green that's been injected into the hand. And you can see these little spider-like channels, which are the lymphatic channels, which show that there is some intact flow. And then just drawing a variety of lines to sort of mark those preoperatively. And then you end up with an arm like this that has marks all over it, and then to follow the anatomy atlases, the blue is veins. So veins that we could consider using for bypassing. So you get things like this with the indocyanine green angiography. So you get different patterns. So on the left, you can see some channels that look like they're actually flowing. So it looks like they're actually, it's not accumulating. That dye is not accumulating. As you move more towards me, you get things called splash and stardust, and then you get diffuse. That means that it's not traveling. It's just basically staying there. And that's important to know for some of the surgical, physiological surgeries that I'm going to talk about, you need to have intact. You need to have some intact. We know that they're not fully intact, but some should still be intact if they need to be bypassed. So that leads into the reconstructive surgical options. So you taking that lymph and just diverting it. So saying, okay, well, it's not going where it's supposed to, so let's see if we can take it to another area, and which is often into the venous system, which has a lot of collateral flow. So that, you know, if there's a secondary lymphedema, then the general surgeon, you know, removes or clips some of the veins, but you have so much collateral flow that it should get past it. And so that's where most of these came from. The first one is something called lymphatic bypass. So it's older, and I'll show you some pictures of it. It's not used as much anymore. The second one is lymphatic venous anastomosis, or LVA. The sexy one is the vascularized lymph node transfer. So taking lymph nodes from somewhere else and placing them in whatever spot you choose. Free tissue transfer. So some of you who have had reconstruction, so breast reconstruction using your abdominal free flap or tram flap, the up flap, does have some evidence that improves lymphedema. And then often combination. I think that's what, especially when people are considering going to the vascularized lymph node transfer route, you may need a combination. So lymphatic bypass was taking lymphatic vessels from somewhere else, which is often involving a large incision on the medial thigh and going down past the knee, dissecting deep, and usually taking those ones that are underneath muscle, stripping those out of the leg, and then putting them into an arm, putting them into the other leg, and connecting them under the microscope. But a very large scar and very likely incidence of causing lymphedema in that extremity. And the patency over time was never really established. But quality of life was improved in those individuals that underwent it. And it involved some ingenuity. It was sort of probably a good starting point for the physiological procedures now. And this is a schematic that's showing bypassing that armpit, bypassing that axillary zone that's been affected in cases of secondary lymphedema, and going from the upper arm, which maybe still have lymphatic channels, and bypassing it right into the neck, where maybe it's not affected. But again, you need that long strip of lymphatic tissue. This was another one that was sort of ingenious. Okay, well, why not take some from one leg, keep it attached, and then just transfer it across the groin and drain that. But again, you can see where that incision is made on the medial thigh has a high incidence, irregardless of causing lymphedema. So, and then again, the patency of it over time was never really discovered. So that leads into lymphatic venous anastomosis. So concentrating on that superficial lymphatic collectors, some do the deep lymphatic collectors, and just taking a nearby one lymphatic collector and transferring it to a nearby vein or venule, and just bypassing the entire area that's presumably causing the obstruction. It, again, was one that required having those good optics for microscope. So you need to see these lymphatics, which are fairly small. We're talking about 0.1 to 0.6 millimeters in diameter, so like extremely small. And then having the instruments to utilize it and dissect it and put sutures in. And microsurgery itself is what we do for flap surgery and reconstructing breasts. And those vessels that we're doing for those are in the order of 2.5 to sometimes 3 millimeters. So this is, you know, pretty small. This is super microsurgery. And definitely required those changes in instruments and changes in imaging modalities. So again, most of the evidence is on the subcutaneous, those collectors, because you're not having to dissect down deep. You're trying to find them. You can actually find them with that indocyanine green because it doesn't penetrate down to these ones. And then you can find where they are, or at least have a decent roadmap of where they are, and then and make small incisions and find a nearby vein, which is often not the major problem, and transferring it over. So this is under the microscope. So on the top, you can see that's a lymphatic. And on the bottom is a vein that's of similar size. And they're pretty small. So just in the fatty tissue, that's fat that you see on either side. A little blue that we put down underneath there is a blue background that we put on all microsurgical cases so you can actually have a contrast so you can actually see. This is a suture they place underneath, so that's a 5-0 suture. So that's, you know, even smaller than what's commonly used for anything, just suturing up like a laceration. You use something called a 4-0, and as you go lower, so if you go up to a 2-0, you know, 1-0, those are bigger sutures. This is put together with an 11-0 or 12-0 suture, and that's a 5-0 suture. So that's, you know, that blue is suture is even small for emergency physicians. And this is, you know, it's stitched together. So this is, you know, you can see the fine sutures compared to that big blue cord, and lymphatic transfer to the vein. So again, it requires having something intact. You can't just say, okay, well, I'm presuming there's a lymphatic there, and everybody has them mostly, unless you have congenital. And let's see if we can just bypass it. Well, you know, that lymphatic channel may not be functional, and even if it's not, then you can't really expect it to transport. So you need to have some sort of pressure gradient. You need to have an area of high pressure to area of low pressure. So lymphatic system is often under high pressure because you have that backflow, and the venous system is often under low pressure. So it makes sense. But if you have something that's not actually contracting and pushing that fluid along to begin with, it's too much to ask that it's going to transfer into that vein. What's debatable is how many of these should you do. So to do one, you know, takes, you know, an hour and a half, 2 hours. To do 4, that's, you know, almost most of a surgical day. So you know, it makes sense that the more you do, the better. You're asking something that's 0.5 millimeters to, you know, times 4 or 5 of them to sort of magically solve everything. I think that's asking too much. I think that's, we'll talk about it, that it's probably valid in those that have mild cases of lymphedema, that don't have that extra hypertrophy tissue, that don't need huge volume reductions. I still think that most people need compression garments after this, but it can be done again. So you could have it one session and then come back, you know, a year or 2 years later and do it again. And overall lower surgical risk, because the incisions we're making are, you know, only a centimeter or centimeter and a half over top of where those lymphatic channels are and where a nearby vein is. So we're not having a huge incision up your arm or leg, and we're not removing tissue from another part of the body and putting it in the area that's affected. Again, difficult to determine which ones. So that comes down to David Chang, for instance, who, the guy in Chicago, does LVI on everybody. Starts out with that for everybody. And if that doesn't work, well, then you can go to plan B and plan C. And plan B might be a vascularized lymph node transfer, and plan C, I don't know what it might be. But it, you know, I think some of the big names will just do what they're most familiar with, and then adjust from there. So I think we know that you have to have something intact, and sometimes we don't know that until we're in the operating room and we're using that SPY system. We're not allowed to really take it out of the operating room. It's $250,000, that machine. So I think I had a sweet talk one time just to get it to go to a unit and to look at something, and I think I had an arm guard basically with it, but you don't often know. But it probably effective in early disease. So asking a limb that's twice the size, asking this technique to deal with that is probably asking too much. And what we've seen is that secondary lymphedema is definitely treated better than primary, likely due to that pressure gradient. Nobody really knows. And then upper extremity is better than lower extremity. So that's something that's universally proposed in the literature. And again, David Chang, who does almost all of them, I think, in the US, it seems, publishes a lot, and that's something that he's found. Outcomes aren't bad. So you do get volume reductions, 42%. That's maintained. Again, in very compliant patients. People had improvement in their symptoms, decreased bouts of cellulitis again. So again, nice to see. And then subjective improvement. So that's, basically probably more important than surveys is, how do you think your limb is? And people that had LVA had lighter and softer they felt. So it has a role. One of the groups is an Italian group called the Campisi group. I think it's still a father and son team, and they would do a combination of the superficial one and they do the deep one, and they looked at what the reductions are, and the bottom bars is normal, and then as you get higher up, you can see the different stages and grades of lymphedema, and you can see it's less effective in those cases. And so I think, again, it's still asking a lot for those little channels that are being connected to actually try to decrease that volume significantly. So then it comes to vascularized lymph node transfer. So it's transferring tissue that has lymph nodes in it to the affected limb, and then connecting it to an artery and vein again, so that flap of tissue, which is either skin, fat, muscle with lymph nodes that has its own blood supply, is placed there and can function. And it's not taken from somebody else, it's from yourself. So you have to have donor sites, and you have to be aware of risks, and we'll talk about some of those. But it does have noted benefit in both primary and secondary, which we haven't really seen very much. We definitely didn't see that for the LVA procedure. The mechanism is unclear. So there's two main theories, and that's separated by the groups, Meng-Wei Chang in Taiwan, and the Americans, who have different theories of why it works. One thinks that it's actually a sponge, so the top one, so that you place it in an extremity, for instance, at the wrist, and it acts as a sponge, collecting up the lymphatic fluid and dumping it back into that vein that you've now connected. The second group thinks that it actually stimulates new lymphatic channels, so called lymphangiogenesis. So that presumably, again, that term VEGF comes up, and it's thought that VEGF is excreted and causes new lymphatic channels to form towards those new lymph nodes. So where can you take them from? So the most common spot was the groin, because it had a well-known vascular or lymph node basin. There is a flap that's right over top that has skin and has fat and has lymph nodes just underneath it that we will occasionally use for other reconstructive techniques, but definitely has the risk of causing lymphedema in that extremity. And we'll talk a little bit about how some of those risks have been, I wouldn't say reduced to zero, but decreased. Supraclavicular, so neck, submental, just underneath the chin, thoracic, which is on the side, and then one that was receiving a lot of attention at the meeting this year was omentum, so from inside the abdomen, around the stomach. So this is the groin lymph node. So on your left, you can see the inguinal ligament that's sort of going across, and you can see the green, which again is lymph nodes and lymphatic channels. And you can see ones that are presumably draining the abdomen, and that's what is incorporated in a vascularized lymph node transfer from the groin. You want to leave the ones that are draining the leg, because then you'd cause lymphedema. You basically move back to square one on a different extremity. And you have to design it so you actually have a flap of tissue with it. So that's for monitoring purposes. There's no point of doing this procedure that might be 6 to 7 hours and hooking up that artery and vein and burying it into an arm and calling it a day and say, okay, see you later, go home, without knowing that it's still functional. So the skin island on the outside, which is this, tells us that that artery is still perfusing that skin and the vein is still draining it. And so therefore those lymph nodes should also still be perfused. Supraclavicular, so up at the neck, and it's it's thinner. It does leave a fairly prominent scar. You're digging down pretty deep, so you can see that big blue, the jugular vein, carotid arteries right there, phrenic nerve that also innervates your diaphragm is there. So probably a little bit riskier, probably less risk of causing lymphedema to the face or to the neck. Very popular in the Asian countries, so Taiwan, that find that those risks are acceptable. Submental, so just underneath, so that's newer. So this flap of tissue, for instance, is used, only came out about 10 years ago, where we could lift that up and then transfer it to a nose if we really wanted to, for somebody who had cancer and required a radical excision of part of their nose. But there's also lymph nodes there. So, and it's based off the submental artery, which is a branch off the facial artery. But again, has risks. So that scar is right across your chin. You have a nerve there called the marginal mandibular nerve that if you bag, you basically don't have much movement of your lip. So very risky. But again, very thin flap, pliable, vascular anatomy that's well defined, and has lymph nodes. And then omentum. So not thinking about anything for that skin island. So now they're just burying this in an arm, burying this in a leg. So it requires an incision in the abdomen, dissecting down to the stomach, isolating this drape of tissue, which is mainly fatty tissue, but has a lot of lymph nodes in it. And then dissecting out the artery and vein and pulling it out, and then connecting it to artery and vein in the leg, or artery and vein in the arm. And then closing it up. And some can do it laparoscopically. So if anybody's ever had their appendix out or gallbladder out, you can do that laparoscopically, but not all people can do that. But it was one that was very, very sexy at the meeting this year. And they were doing some pretty advanced things with omentum. You can sort of split it into two, like you can see on the bottom there, and you can then sort of transplant it to different regions of the arm. But again, no monitoring. So you actually have to put, we have a little Doppler, if anybody's ever had a flap, where you can listen to that blood vessel on the outside, but you can actually put a little cuff on the inside of the blood vessel, and has a little wire connector that comes out, and you can listen to it, which is always risky, because if somebody yanks on it, you think you might yank out the artery or vein, but that's the only way of monitoring this. And this is omentum. This is something I did in my fellowship that we used for something else different, but that's what omentum looks like. It's a big fatty drape of tissue, and everybody has it. But again, has risks. So intra-abdominal surgery, that's a big surgery. That's, you could run into bleeding. You could run into a perforation of the bowel. You can get inflammation. You can get a hernia. So, fairly extreme for lymphedema, for trying to harvest lymph nodes. So again, it comes back to indications. So who qualifies for this? And nobody knows, because everything that I've talked about has been around in variety of shapes or forms, but never really has been applied in a widespread group of people, or group of individuals, group of patients. And I think you have to weigh the risks. I think you have to weigh, what could potentially happen with taking lymph nodes from the groin, what could potentially happen with, this omentum. And I think that's led to where, it's best reserved for very significant cases of lymphedema, because everything else has been tried. The non-surgical management is not working. The LVA procedure, there's no intact lymphatic channels. But then it becomes, where does that liposuction, where does that debulking fit in? And some will say, well, we'll do this and we'll put it in the arm, and then we'll see what happens. And if they need something later, then we can always do a liposuction, or we can add another lymph nodes to the arm. But I think debulking is still something that I think should be primary. It should be, you give it a sort of a benefit of the doubt, trying to have a good chance that you get rid of this extra tissue, get rid of the extra fat, and then now physiologically, maybe you can reset the time. Debatable concepts. So how many lymph nodes? So four enough? I don't know. Is 10? Nobody knows. You're basically just taking a group that you know are there with an overlying tissue. Where should it be placed? And that's a hugely debatable concept, because it comes down to what the proposed mechanism is. So those that think that it acts as a sponge say, oh, you should put it at the wrist, you should put it at the ankle. Those that think they're actually forming new lymphatic channels say, well, actually, you should put it in the place that was affected to begin with. So you should put it in the armpit, you should put it in the groin. And then there's a movement towards double level. So with that omentum, you could separate it into two, and then you could sort of tunnel it underneath and put one into one area and one into another area, as long as it's long enough. And so you have sort of two areas that are presumably draining that lymphatic tissue or that lymphatic fluid. So risk, lengthy surgery. So this is like doing a flap. This is an entire day. This is booked off an entire day, usually 2 surgeons, sometimes 3. Similar to transferring tissue to another part of the body. That's what we're doing. Risks of scars, inherent risks for the different sites, conceivable injury, significant nerves, blood vessels. Yeah, we can put them back together, but nerves, if you cut them, the chance of you getting full return of function is rare. You know, you get a complete cut, you're probably only going to get about 60% function back. And then potential to cause lymphedema at the site you take it from. So we're not built with much redundant tissue in our body. We're certainly not built with a lot of redundant lymph nodes in our body. So you could cause, they're there for some reason. So you could cause lymphedema. And so that's when this group, Joe Diane and his partner Mark Smith, decided, well, can't we label, especially when it comes down to groin, can't we label those lymph nodes that are draining the foot? And can't we label the ones that are draining the abdomen? And then only take the ones that are draining the abdomen and leave the ones that are draining the leg. And that's where they came up with this reverse lymphatic mapping. So injecting that dye, that tracer that was used for the lymphoscintigraphy into the foot, allowing it to work, and then injecting the indocyanine green, which, you know, incidentally we have, into the abdomen, and then seeing where they go, and leaving the ones behind that have the technetium. This has been our holdup, is getting access to the technetium, because it's a radioactive tracer. We have the green, we just need the technetium, and it's sort of one of those things where you're impeding on other people's territory, and that's a territory of radiologists, and so, you know, they don't like sort of, you know, when we eventually got X-ray machines in a place called Minor Surgery Clinic, where we fix all the broken hands and stuff, they didn't like that, because that was their territory, and it's better for patient care, but it didn't really matter. It was territory. And this is somewhat similar, we're finding, with the technetium. So the outcomes. So no large studies yet. You look at the big centers in the US that are doing it, and you know, they may have a handful, they may have 25, and really nobody's been followed out past 5 years. They have reductions in volume and circumference for sure, seen by many groups, and similar in the lower extremity, which again is something we're not seeing for some of those other techniques. Health-related quality of life improves, bouts of cellulitis improves. So again, sort of similar to those other ones, but seems to be more versatile, seems to apply to upper and lower, seems to apply to primary and secondary. So, you know, it's probably going to be something that's going to be staying around for a long time once we actually define it a little bit better. Fourth, so just transferring tissue. So this popped up when I gave a talk to the surgical oncologist group at Foothills 3 or 4 years ago, where I couldn't actually see the audience because I was giving it from another site. And somebody in the back put up their hand, I'm assuming, and asked a question. It was a surgical oncologist, and said, do you actually see the lymphedema get better when you guys do these fancy flaps that you talk about, these tramp flaps? It's like, oh, yeah, there is some evidence that it does. So, you know, it varies. That the thought is that you're almost acting as a bridge for the lymphatic flow. So you're taking that tissue, you're taking fat, you're taking skin, and it's actually forming new channels. It's miraculous to see what happens when we do transfer that flap to reconstruct a breast to fill in a groin defect. And you cut into it 2 years later and little blood vessels bleed because they made their way across that scar site. So if that happens, then the lymphatic channels should do the same thing. And it's sort of varied. So some have seen it, some haven't. And then it sort of expanded. So the question is, well, if you're going to reconstruct my breast anyways, can't you take lymph nodes that are down there too? And that's what this is doing. So you could transfer that tissue and transfer some lymph nodes and then hang those lymph nodes out in the armpit and anastomose those. And we've done a couple of these cases, and it seems to work. I think it's never gotten rid of compression garments for sure. But it makes sense. You're in the zone. It only requires an extra few centimeters of dissection probably, and you got lymph nodes. So, and then combined treatment. So again, probably the most common. So I think it needs to be a hybrid model. I think that just thinking that one technique is going to solve everything is not going to work for the vast majority of individuals. And combining things like a debulking procedure like liposuction with an LVA procedure or vascularized lymph node transfer is probably what needs to be done for people that have very severe and even moderate severity lymphedema. And then combining both of them. So combining an LVA, combining a vascularized lymph node transfer, that's, again, evidence that we have more evidence on the LVA. It's been around for a little bit longer, but I think we're eventually to get that evidence on that. It's a combined and additive benefit. So again, patient selection is largely unknown. It's the articles that are out there never really talk about it. People propose their own algorithms and the way they go. And I've emailed some of the big individuals, and they never respond to emails. They never get back to you. They never talk about post-op protocols. They never talk about how often people are being wrapped. How often are people in the hospital for these procedures? I did see that in Taiwan, I think the people were in hospital for those vascularized lymph node transfers for 2 weeks, which is a long time. People go batty in the hospital within a couple of days. So I think, I don't think it's been defined. I think it's something that comes later. I think that comes later for a lot of stuff in medicine. I think this is one that isn't dissimilar. I think we have to have a compliant patient. So you have to have somebody that's willing to see the therapist, that's willing to undergo compressive wrapping, that's willing to go and see their clinic for lymphedema, because it's still a huge part of the treatment. Realistic expectations. You have to have decent idea of what's going to come and what potentially the risks to be. I think that for the physiological procedures, what I've gleaned is that LVA is really good for mild cases. It's good for early cases. It's good for limbs that are easily managed with compression. It's just people want that added nudge to sort of get the volume down less. In later stages, that's probably not an option because the lymphatic channels have fibrosed and they're not functional anymore. So now we need to bring new tissue in. This was an interesting article in 2018. It was out of California, and they looked at expectations. And they looked at expectations of patients at their first clinic visit to one of the lymphatic surgeons. And greater than 50% expected huge response from vascularized lymph node transfer, LVA procedures, and early, within 6 months. I think it's going to be all resolved. But interestingly enough, it was the source of information that skewed them a bit. So ones that actually had their family physician talk to them that they may have thought didn't know very much about it had lower expectations and lower demands, I guess, or overall expectations than those that learned from the internet. And again, I think that comes out with some of the surgeons can be used car salesmen a bit. That it's going to be, this is the end all. It's going to work, and your life is going to be changed forever, and burn that compression garment tomorrow. So I think expectations have to be key in that patient selection. The unknowns. So long-term results. Oh no. Liposuction, LVA, yeah, they have fairly decent results for long-term, but the vascularized lymph node transfer doesn't, and it's hard to compare. It's hard to compare that group versus that group because everybody's protocol is postoperatively different. Everybody's dissection is different. Everybody's anastomosis is different. Everybody, maybe the antibiotics they give are all different. So it's hard to sort of say that group A does this and group B does that, and they do it better because it's hard to compare those. Safety. So I think safety is something we still don't know. Like, if you don't develop lymphedema in the extremity that, the groin or neck, like what about in 5 years? I don't know. Nobody knows that. And then protocols. Nobody talks about those. Not at any meeting. One surgeon did, and she happened to be also be a lymphatic therapist, lymphedema therapist. And so she talked about her protocols, but nobody else. And then the other unknown is what I talked about is patient selection. So emerging concepts. So potentially new donor, maybe not so much donor, but recipient sites, where to put them. We discover a lot of everything that we do now based on anatomical dissections. So finding a new blood vessel, an artery and vein to connect to, and different zones are, every year we're finding something different. So that gives us another option of where to connect that lymph node to. More defined imaging. So this is an MRI. This is an MRI of your lymphatics. So that gives you way more definition than that X-ray that you saw of the lymphoscintigraphy, and gives you much more than the ICG. And they have MRI of veins, so you can even look at nearby veins. So that's sort of a concept that's emerging. Will it be used intraoperatively in Canada? Probably not, because of the cost. But it's interesting because you can define things a little bit more preoperatively. Combining approach. So the whole combination concept here, where they're doing double vascularized lymph node transfer and removing debulking tissue, and seeing the outcomes. And this, I think, is only from 2018. So this is where the movements are going, is taking it to the next level. Dividing it. So as I talked about with Omentum, so taking two parts of that, from that curvature of the stomach where you have those lymph nodes, and putting them in different sites in the same limb, is another way that's being advanced recently. So double lymph node transfer. So in conclusion, yeah, advances have been made. I think the concepts have always been there. I think when it comes down to surgical options, debulking, probably nobody's going to want to go for the Charles procedure. Cyst trunk procedure, probably not. Liposuction, I always thought it was an adjunct. I always thought it was something okay, we could add on to something else. But I think it's also primary. I think it has decent outcomes. It seems to be reproducible. LVA, so in those individuals that have intact channels still, vascularized lymph node transfer, I think, is still on the cusp of being widespread, and there's still only selected centers doing it. But I think overall the majority, it comes down to expectations. I think this is Keaton Patel from USC that, in his large clinic, the one that also talked about the expectations overall, says that this is what you should expect. Thank you.
So let's open for questions. So where in Canada are we doing it? I think Montreal,
Yeah, like we're doing that. I'm doing that. Well, we've done vascularized lymph node transfers. We've done, definitely everybody should be able to offer liposuction and LVA. So you're right, Canada doesn't have a lot Toronto was one of the ones, but I think that guy retired. Again, you need to be. It comes down to money. You need to be in that large center. You need to have that imaging system. You can't just go out willy-nilly doing it. And when you're talking about an instrument that costs $250,000, not every province is going to afford that. I know Quebec had somebody that was promoting it, but I don't know. I've never heard of them. So Toronto, I've heard of the ones. Winnipeg might be developing a program. Nothing in Saskatchewan, and BC, as far as I know, none. Like, I don't think Dr. Azerud's doing it in Duncan. So yeah, it's limited. It's I think some of the residents that are being trained now are actually going more into fellowships that are in lymphatic reconstruction, because it certainly wasn't a program that was around 10 years ago. There wasn't a lot, like some of the top microsurgeons go to Taiwan. That's always been the case. And that was from a guy named Fu Chen Wei, who was originally trained in Toronto. And he was Taiwanese and went back and started a massive program where they probably do, 10 of these a week. So their volumes are huge, and they've developed subsequent training programs, and slowly we're catching up, but I think we're way off, because part of it has to do with trying to coordinate clinics and trying to coordinate a multidisciplinary team, and that involves a lot of logistics, and we just haven't really, certainly won't do that in smaller centers.
With regards to liposuction as considered a primary treatment modality, what kind of reductions percentage-wise are you getting? How long does it last?
Yeah, so the reductions, I've definitely removed 1,000 cc's out of an arm. I would say the only limiting factor for me is the post-op protocols. So the ones that get the massive reductions, the ones that are getting 110%, are wrapping people tightly in the operating room. And so that surgeon named Shavarian, who is one of the big names in liposuction, will actually get the patient measured for a compression garment on their contralateral normal side, and then put that on intraoperatively on their lymphedema side after liposuction. I've been a little reluctant to do that yet, because I think what we've always been taught throughout all of our training is don't put dressings on tightly, because you can constrict off limbs. And certainly I've seen limbs that have been constricted off with Coban because they're wrapped too tightly. And if if your limb is slightly anesthetic because we put freezing in that tumescent solution, well, we don't want that to happen. And then now your fingers are dusty. So I've been hesitant. The company that makes Coban wanted me to wrap people intraoperatively, and I was like, go gangbusters. I think it's a little bit worrisome to do that when somebody's under general anesthetic and they can't tell you when that really hurts. So can it be repeated? Yeah. Oh yeah. Like liposuction, can be done anytime. I don't think anybody's ever, again, done long-term studies saying 3 or 4 times being done. It keeps adding up and it keeps improving. And certainly the long-term results seem to be there, as long as you're compliant. So again, that's the caveat.
You know, when are you planning to do the procedure for kids with family?
Not yet. So it's not only in lymphedema we have issues with that transfer from children to adult realm. We see that for all sorts of things. We're seeing that certainly in the transgender population as well. So not currently. I don't know anybody yet in Canada that's doing it on children. Again, it just seems to be everybody's concentrating on the secondary right now. When I went to a lymphatic surgery course, which was given in Philadelphia 3 years ago, there was only 2 people from Canada at that course, and one was from Toronto. And he worked at Sunnybrook, so it was only adults, and I think he's since retired, but nothing yet in Canada.
We're in Calgary here as therapists. Where should we send patients? Where do we find a doctor who even sends you to you? Like,
Yeah.
how does that
Oh yeah,
work?
there's been some pretty serpiginous routes that people have made it to me. I've had pages when I'm on call or not on call about can you order lymphoscintigraphy for me from a family physician's office, and I'm like, I'm not the gatekeeper of radiology, so you can. But yeah, so often they just get referred to my office, and there's been some movement. There's still that division in Calgary between cancer and non-cancer lymphedema, and the clinics are different. And I don't know if they even talk to each other, but they were trying to sort of pull things together with a team of internal medicine specialists and physiatrists, and I don't know where that is. I think it's sort of fallen by the wayside in the last year or two, and they're trying to have a nice process for referral, and all the boxes would be checked, because in cases of secondary lymphedema that may not be related to surgery, you have to figure out why is that limb swollen, and one of the things is a venous obstruction, so or cardiac, so that has to be worked up more from internal medicine, and then almost lymphedema is the diagnosis of exclusion in those individuals. So yeah, the path is all over the map. So, I'll get referrals from other plastic surgeons in town that are, that they'll get referred. So I think that's the good thing about Calgary, is that, and Edmonton, I think there's no major segments, or these surgeons don't talk to these surgeons. I think that the group is pretty universal. I wouldn't say the same thing about Vancouver, and Toronto's just too big. They got so many different hospitals, and they have their own groups. But I think in Calgary, if a surgeon from my division identifies somebody with lymphedema, it's often sent my way.
So if I have patients who are interested in coming to see you, do I send them to the GP and
Yeah.
to argue with them?
Oh,
if he sends it,
sometimes I've got.
Can I contact them and set up?
Yeah, you can. Yeah, you can send it to me. Yeah, I've definitely done that with some of your colleagues. Yeah.
And Dr. Jeffrey Schaefer, who's internal medicine, he will diagnose any patients for, I've been in contact with them, and they're just working on the logistics and protocol. So if you send it to him,
I think he's
at the Foothills Hospital.
I think he spent some time at Rockyview too.
Yes, and there's another doctor that's now connected with them, and they're just working on trying to get it set up. So, but Dr. Jeffrey Schaefer, he's internal manager.
Internal medicine. Yep.
Yes.
Yeah. To like a hand or to a leg, or I think it's a consideration. I think that's where those that workup and anatomically comes in. I don't think it's out of the question, because we know that one common mechanism, I guess less common than malignancy, is trauma, and I think we'd have to find out what is available. We'd have to find out what's available for venous function and what's available arterial, and if we're planning on anything like a vascularized lymph node transfer. If you sometimes when people have a degloving injury of a foot or a hand, they've lost some of the main arterial. Oh, okay. So almost like the Charles procedure. Yeah. I don't think anybody has really done a lot. I think you saw one of the articles that I showed, one of the last slides. It was the combined, and they had done a debulking procedure at the same time as vascularized lymph node transfer. So yeah, I think it's possible. I haven't yet, but it's definitely something that's available. In the corner.
So I have ordered lymphoscintigrams, and it's frustrating on legs because I see patients that have toxic lymphedema. I send them for a lymphoscintigram just to prove it, because they want clinically it looks obvious, and then the lymphoscintigram comes back normal. Yeah. So then the patient, of course, doesn't trust me anymore, won't take my advice for compression, etc. Doesn't believe me, goes shopping elsewhere. I try to tell them that means the lymphatic channel
So they're rare. And there is a couple articles that have shown that people who have normal lymphocytography still have lymphedema for sure. And that often what they do is they repeat the lymphocytography and then it's abnormal in 90 to 95% of the cases. So they did it anywhere from 6 months to a year. And that was only in a segment of, I think it was 15 patients that had obvious symptoms of lymphedema but had normal lymphocytography. I think the other thing we have to consider is that lymphocytography is really only looking at the superficial, so it's not going into the deep system. And so, is that a consideration where, if you eventually get to the MR, lymphangiograms, that I haven't ordered it. What's happened with a lot of the radiological things that we do, we have to make sure that there's a protocol for timing of dyes. We saw that a lot when we brought CT imaging of looking at what we call little perforators that are going out to the abdominal tissue for doing free flaps for breast reconstruction. And if the timing's off, you miss it. It's not there anymore, and it's already gone to the venous system, and you've missed your arterial phase. So I think I haven't ordered it, but I think it's something that should be there soon. I am talking to a radiologist in the next day or two, so I'll ask him that.
In terms of post-op management, you mentioned still needing to wear compression garments. Is it just maybe a reduction in how frequently you have to wear them, or?
Yeah, so it's that one, that at the end of most of these articles, people will say, oh yeah, people got rid of their compression garments. And I think that in reality, that's hard. I don't think that's doable. I think, again, those protocols aren't really shown. And I learned from patients, actually. I learned from patients that went to other countries and they came back and I said, what did Dr. So-and-so do? Oh, I had to go there for, 2 months ahead and they wrapped me every day. And then we had surgery and then I was there for another month. They wrapped me every day and then they sent me home. And that's not something that's ever going to fly in a Canadian healthcare system. So I think I specifically tried not to put pictures in there in my talk of what the limb looks like preoperatively and what it looks like postoperatively, because a lot of these meetings, a lot of these articles have, oh, this is what it is. And it's always the best case they have. And you look at it and they say, oh, it's 120% reduction. You're like, it doesn't look like 120% to me. It looks like basically what the pre-op photo looks like. And yet they'll still say they got rid of their compression garments. So I think in reality, maybe you can have a reduction in the amount that you're using compression and what your therapy is. But I think that's our most optimistic outcome. Yep, in the back.
I had a question and I wear my compression garment every day, and I noticed that if I don't wear it, it right away starts to increase, so I have to wear it all the time.
Yeah.
And I noticed a reduction in my upper arm, but on my lower arm, I hadn't any.
Okay.
So I go regularly to get wrapped, and then I get remeasured.
Yeah. So I think hand is one that we can never get adequate reductions in with liposuction because there's really not much fat in there. I think forearm definitely has less, and then upper arm usually has pretty good results. That's not something that's going to be in articles. That's not going to be something that's going to be in textbooks. And I think, again, the individuals that have the great outcomes that we see in all of the literature have that very aggressive wrapping and very aggressive compression, which we haven't done yet because we don't have the resources. And again, that's not highlighted. That's not on the second paragraph of the paper. That's buried in the last paragraph of results. So again, I think liposuction still has a role. In the back.
Where's the new trend of the momental
flap? Yep.
Is there any discussion about post-op?
No. So,
It's good because that's a lot of stuff happening, especially
yeah.
for the microbiome.
Yeah, that's sort of where I was like shocked when I was sitting in there, and I was, I always knew about it, and we've done certainly some of the momentum to reconstruct other parts of the body, but yeah, they were pushing it, and they were having some, most don't want to show like their bad results. So there was some, and they were showing, you look at momentum, and momentum is heavily dependent on body mass. So the bigger you are, the bigger your momentum is actually going to be. And if you put a giant piece of momentum into an arm, it looks like a giant piece of momentum in an arm. And that's what some of them looked like. It was just, I didn't want to, I was shocked. Like it was, and they were like, oh, we don't know why this volume's bigger. Well, it's because you got a massive momentum in your arm that may or may not be alive. And, so yeah, post-operatively, they didn't talk about the abdomen. They didn't talk about, was there bouts of perforation? What happens when you put that momentum for the biome in that arm? If you change that environment, nobody's really looked and sampled and compared pre and post. So no, I think it's still something that's new on the horizon, and it's just pushed extremely. And I think what I'm trying to convey is that there's always these sexy options that pop up and then they disappear. We've seen that in all segments of surgery where this was the end all, and it fell to the wayside, and only to sometimes be redeveloped later in a different format. I don't know if the momentum will be that.
We're just going to take a couple questions from the people in here.
Here?
Yeah, go to Q&A, and then it's live now. It's live.
Okay, so the question was, is the incidence of lymphedema at donor site with vascularized lymph node transfer reported? It's not reported. So the evidence has been used routinely the most in all of lymphatic surgery, and it's just theoretical risk. There was no, well, it's 10% chance. So, but with that theoretical risk, you all know that have had lymph node dissection that don't have an IV put in that arm, don't have anybody to measure blood pressure off that arm. Is there evidence for that? No, there's no evidence. That's all theory. Do we want to change that? No, certainly don't, because who wants to be that person that said that? So I think the same thing is with the donor sites, is that the theory's there and it makes sense that it could potentially occur. And the retro mapping has came out for the groin to try to obviate that risk.
Any other?
So we discussed about the procedures for the surgeries and about the compression guidance. What's your opinion about the compression pump device? Yeah, so it's sort of outside my realm, but from everything I've read, and maybe the therapist will know a little bit more about it, it does have good evidence. It was, I think, a lot of the information in lymphedema doesn't have rock solid level 1 data because, what we talked about, because it's not really readily discussed. And I think most of the literature that I've seen for pumps has had decent effects, and they've had, decreased bouts of cellulitis that has been shown again for that. And overall improvement in quality. I don't know if anybody's ever done studies in terms of the circumference. I don't know if there's been any quantitative data, but some of the therapists might know more about that.
Anything else?
Oh, there.
Have you dealt with mixed forms, like say lymphedema or venous lymphedema?
Yeah,
Do you deal with mixed forms?
We have done mixed. It's still sort of been individual. Like we certainly see a smattering of lipedema, and I don't think I've seen one yet of a combination with venous.
Because lymphedema would be a big thing for liposuction. Yeah, but it's difficult. So it's a whole different can of worms. It's you know, that fat is actually more sheets. It's a sheet fatty layer that liposuction isn't often great for, unless you have a certain type of liposuction. So there's a laser type liposuction that tries to break up the fat using a laser signal. There's an ultrasonic liposuction that tries to blast the fat, and then it gets sucked up the readily available way. The drawbacks of those is that you can burn people. So you can burn people with the laser, and you can burn people with ultrasonic. So it's never taken off. And to remove a fatty sheet is difficult with just traditional liposuction.
We'll take one more question, then we'll have Lee come out.
Sorry, you did mention what the costs would be with regards to the surgery. Is it any of it covered?
Yeah, it's all covered. Yeah.
It's all covered.
Yeah.
And what type of wait period if you were referred to your office?
I think it's like a year. Yeah, I think so. Yeah. My secretary knows better, but every time I say time, she's like, "You're lying." So, yeah.